Hey guys, so in this video I'm going to talk about osteoarthritis, and first thing we have to learn about this is it is actually misnomer. There is nothing like any inflammation, infection going on. It is not at all an inflammatory condition. It's just a degenerative joint disease. Means it is a senile condition, actually happens in the old age due to degeneration of the joint space. And how actually it is happening, let's see. So first, it is a degenerative joint disease, and that's why we can also call this wear and tear joint disease, also known as osteoarthrosis instead of arthritis, that indicates inflammation. Okay, so first we will learn about what are the common joints that are affected most. First is the knee. We know that knee is the most common joint involved in osteoarthritis, happen during the old age. Means mainly the weight bearing joint are going to affect the most, which are commonly used more. So knee, then hip, then spine. In spine, mainly the cervical and lumbosacral spine is going to affect more. And which joint is going to affect? That is facet joint. Now in fingers, mainly the PIP and DIP joint are going to affect. And the second, yes, and the deformities are called as Bouchard's knot and Heberden's knot. So you can remember like this, that Bouchard's knot is in the proximal interphalangeal joint, BP, and Heberden's knot is in the distal interphalangeal joint, that is known as HD. Now first thing we have to learn that after interphalangeal joint we know that there is metacarpopharyngeal joint, but they are not involved. So metacarpopharyngeal joint is not involved, and in the carpometacarpal joint also only the first carpometacarpal, that is in the base of first finger, that is our thumb, only this one is going to affect. So carpometacarpal only the first one, metacarpopharyngeal is not going to affect, and the intercarpal wrist joint is going to spared. So wrist joint and metacarpopharyngeal joint is not going to get affected. This we have to remember. This is a very commonly asked question. And how to differentiate various kind of joint condition is commonly based on their location. So we know that in osteoarthritis there is involvement of the interphalangeal joint, PIP and DIP, but in the rheumatoid arthritis there is DIP sparing happen, and this DIP will involve in the psoriasis. And this wrist and metacarpopharyngeal joint is mainly going to affect in the rheumatoid arthritis. So this location we have to remember. Now the pathogenesis part, let's start. We know that but let's talk first about the osteoarthritis of the knee. Most common bone is patella. Most common compartment is medial, because we know that in medial compartment the weight bearing will be more compared to the lateral one. And most common muscle is also, you can remember from medial side also, vastus medialis oblique. Now how this degenerative process is going to affect, so you can relate this degenerative process of osteoarthritis with that of your old house. We know that in old house there is what is called the humidity. Yes, due to humidity we know that the walls, the painting, it going to start fell off, and we can see the nude wall without paint underneath that. So same thing is going to happen. Same thing, the stages wise also. First we know that when this humidity will happen, the outer covering, means all the paint will be swollen, and then some cracks will appear, and after that some part will fall off, and at some point of time, if there is too much, the whole point can be fell off too. So this process, we know that we have seen it in our houses also. When the humidity is too much, we know that what will happen to the outer covering. So same thing is going in the joint also. As we age, what is going to happen, there will be increase in water content. So due to water content increase, all this problem is arising. There will be first softening or edematous articular cartilage will be there, and after that fissures or fragmentation or cracks will appear, and in stage 3 there is partial detachment, and in stage 4 there will be complete detachment of articular cartilage, and this will lead to the exposed or denuded subchondral bone. So this we have to remember, that due to this exposed bone, various kind of things is going to happen. And in X-ray, what we are going to see, first we know that asymmetrical reduction of joint space is going to happen. When medial side is going to affect more, so there will be asymmetrical reduction of the joint space. There will be formation of osteophytes and loose bodies, and there will be subchondral sclerosis plus subchondral cyst formation. All of these changes is happening due to this exposed bone. Due to this exposed bone to the synovial cavity, this changes will happen. Cyst formation will be there, sclerosis will there will be osteophytes, there will be loose bodies, and all of this thing we can see in the X-ray, and we can diagnose this by X-ray of both knee joints. We can do the epistanding view or lateral view. But what will be the patient's complaint? So most common symptom will be knee pain, and first sign will be tenderness, and there will be bony crepitus also, and due to pain there will be reduced walking distance also. And we know that the deformity in G. genuvarus bow legs will be there, PIP Bouchard's knot, and in DIP Heberdine's knot. And how are you going to manage conditions? So first we have to do the symptomatic management. So the conservative, we are going to offload device, means we are going to progress the disease by reducing the work of the joint, so more damage won't happen. So first we are going to offload the weight that is there in the degenerative joint. So walking stick, and we have to hold it in the opposite hand. But some people are ashamed to go out with walking stick in the hand. So there is also one device, that is hinge knee braces, that will do the same work, and we can give intra-articular injection of the visco supplements, that is hyaluronic acid, and what it will increase the viscosity of synovial fluid. So more there won't be any more friction between the two bones at the joint site, and this can prevent the damage actually. And we can indicate some exercises like isometric quadriceps strengthening exercise. Now the painkillers, mainly the painkillers, we can start off with the NSAIDs, and the safest one is the PECM, paracetamol, acetaminophen, and this etoricoxib is a wonderful drug, and with less GI side effects. We can give some topical management like topical liniments, lotion, and oil. And glucosamine, diacerin, chondroitin sulfate, adenosyl methionine, we can give this kind of medications also. Now operative one. So first what we have done, we have give the symptomatic management. If patient is main complaint, we know that it is pain, so we have tried to reduce the pain by various drugs and the topical management. And we have also tried to reduce the workload of the joint by giving offloading devices and some visco supplements, indicating some exercise also, so that we can prevent the further damage. And the operative management could be by osteotomies, and it is indicative when the disease is too advanced and patient complain more pain. So high tibial osteotomy will be there, proximal fibular osteotomy, and it is mainly done for the deformity correction. I don't know why I have written the connection. You have to correct this correction. Then by arthroscopically we can remove the loose bodies and remove the debris and adhesion, and finally we can do total disc replacement. That absolute indication